This is a 22-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. The talks coincided with the launch of the Small C Public Awareness Campaign. The aim of these talks and the Small C campaign is to improve the early diagnosis of cancer. This talk is about colorectal cancer. It's in two parts. The first is about epidemiology and screening and lasts for 9 minutes. The second looks at surgery and treatment and lasts for 12 minutes. The speakers from Barts Health NHS Trust are Sean Preston, consultant gastroenterologist, and Sarah Slater, medical oncologist, and from Homerton University Hospital NHS Foundation Trust, Sanjay Wijakun, consultant colorectal surgeon.
Colorectal cancer is extremely important. We have over 36,000 new cases per year in the UK and 16,000 deaths per year. If we catch these cancers early, if we diagnose these adenomas early, we can make a huge impact on some of these figures. Colorectal cancer is the second most common cancer. What you're seeing here is the survival rates, the percentage 5-year survival rates for the three most common cancers in the States, in Europe, the English average, and then North East London. And you can see that the 5-year survival rate in the States is 62%, in England we're 49%, North East London, we're the lowest of all around the country, we are 42%. So the reason for giving you these figures is to highlight how poorly we're doing and hopefully give you some ideas of how, my theories of how we could do better. The most important thing I believe in the treatment of colorectal cancer is early diagnosis, and the best way of diagnosing cancers early is through screening and not waiting for symptoms to occur. What this figure shows here is the time from patients noticing and reporting symptoms to GPs, from that GP again being referred to secondary care. And you can see from the top, breast cancer, lung cancer, upper GI cancer, and we're right in the middle here with colorectal cancer, with nearly 60 days from the time of a patient noticing their symptoms to reporting to their GP, and then again a significant lag before that referral is made to secondary care. So here's how we can make a difference in the symptomatic patient. This just shows you the distribution of cancers throughout the colon. You can see the majority are confined to the sigmoid and rectum, so within reach of a sigmoidoscope. But you can see there are a fair number of right-sided cancers, 12% in the cecum and 5% in the ascending colon, nearly 6% in the transverse colon. So far from all reachable with a flexible sigmoidoscope. So what I want to encourage you to do is when you're sitting with your patient in the surgery, whatever they're there for, if they are in the relevant age group, and at the moment we're screening patients from the age of 60, but I really encourage you to think about colorectal cancer in all patients over the age of 50, how you can establish their relative risk for colorectal cancer. And the most important thing in the absence of any symptoms is a family history. If you have one first-degree relative with colorectal cancer, your relative risk for developing the disease is 2.5 times greater than it would be normally. If you've got more than one first-degree relative, this goes up by 4-fold. But what I think is very interesting is even if you have a first-degree relative with colorectal adenomas, which are extremely common in our patient group, that doubles your risk of colorectal cancer. And I want, when you see these patients, if, in the absence of any symptoms, just to quickly go through this and establish if they're in any of these higher risk groups for developing colorectal cancer. This is what makes colorectal cancer so appealing to screening. That it's the natural history. It takes nearly 10 years for that initial mutation at the base of a crypt to go on to form a polyp, then to form a cancer. And that gives us times as clinicians, and me particularly as an endoscopist, lots of time to interrupt that so-called adenoma-carcinoma sequence. If I can, through screening mechanisms, because these patients are normally completely asymptomatic, get the patient at this stage when they've developed an adenoma and remove that, that polyp no longer has any malignant potential. So let's catch these patients early in the adenoma-carcinoma sequence. Here you can see the importance again of not only catching the polyps, but catching the cancers early. You can see in the upper left plate here, a Dukes A colorectal cancer. That patient is likely, if they're diagnosed at this stage, to 90% chance of living for 5 years. As that cancer becomes more invasive, that number, that 5-year mortality figure, drops, and you can see by the time it gets to a stage D, there's only a 5% chance of that patient living 5 years. We want to catch the patient here, or preferably even the stage before this, when they had their asymptomatic adenoma. This is what we're using as part of the bowel cancer screening program in the UK at the moment, which is the fecal occult blood test. And we use the guaiac method, which has a lot of false positives, a lot of false negatives, and particularly, I believe, within our population in Tower Hamlets with a high proportion of Bangladeshi patients, the false positive rate is high. But I'm also scared that we're missing a lot of patients out there with false negatives. We are told, going to be moving from the fecal occult blood testing to sigmoidoscopic screening sometime in the near future, but as yet I'm not aware when that date will be. So you can see with the fecal occult blood test that you're only going to be diagnosing 13 to 50% of your colorectal cancers. If that's positive, you're going to need a bowel prep, you're going to need a colonoscopy. So I must say I'm not in favour of this test and very pleased that we're going on to flexible sigmoidoscopy as a method. So as you can see, the other stool test, the fecal immunohistochemical method, is better. You're going to diagnose more than half of your cancers, but equally just under half of your cancers are going to be left in the population undiagnosed, and you're going to get nearly a third of your advanced adenomas. Where I think the advances are being made and where the future may lie is in the fecal DNA testing, so looking specifically for mutations within the stool. And we're not there yet, it's very expensive, the sensitivity is poor, but I think with further work on that this may be a space to watch. So for every 1,000 individuals who complete the fecal occult blood testing, and again you're missing a population at the top, 20 will have a positive test, and those will be invited for colonoscopy. 4 will decide they wouldn't like to go on to have colonoscopy, but 16 will. 2 approximately in that group will have a colon cancer, 6 will have polyps, and 8 will have nothing abnormal. But that nothing abnormal would include hemorrhoids, a reason for their false positive test. But a lot don't have any reason for their positivity found at all. Dave has given us a big thumbs up for the sigmoidoscopy, so we'll be doing that in the near future. And there's good data from Wendy Atkins' paper published in The Lancet last year that this can impact hugely on the diagnosis, morbidity and mortality of colorectal cancer. But you are accepting that you're only visualising a third of the colon, so it's not a perfect test. Colonoscopy for colorectal cancer screening, you can see half to 3/4 reduction in the colorectal cancer incidence, so very impressive. 31% reduction in the colorectal cancer mortality. But in favour of the sigmoidoscopy, you're really getting that benefit from the left-sided cancers more from the right. It is possible right-sided cancers have a slightly different natural history and progress far more quickly from the adenoma to the carcinoma. But still, it's not perfect. Interval cancers still do occur.
So one of the first things we want to know, of course, is the diagnosis confirmed? Has the patient had a colonoscopy? Are there synchronous lesions? Are there colorectal polyps? So I think anything less than a colonoscopy these days as an luminal investigation for colorectal cancer, once a patient is suspected of having cancer, is really, I would have thought, unacceptable. Secondly, histology. So biopsies may have been taken, but are we absolutely sure this is cancer versus high-grade dysplasia? And that also needs to be clearly established in the first step of the MDT. Where is the tumour? I mean, this sounds relatively straightforward. Is it in the rectum or is it in the colon? Does it matter? Well, this is a sagittal MRI, and you can see here there's an anterior tumour within the rectum. The rectum, we think, starts at the level of S1 and finishes at the coccyx. We think traditionally it's about 12 centimetres in length. There's an anal canal here of 4 centimetres. So the length of the anus and the rectum combined is about 16 centimetres. Now, we do not think that can be clearly evaluated using flexible telescopes, and Sean may have a view on that. So it is vital to know whether the tumour is in this region or up here, both for staging and for treatment. So we would recommend that patients considered to have rectal cancer certainly should have at least a rigid sigmoidoscopy, must have an MRI scan, and possibly a digital rectal examination even under an anaesthetic if necessary. A little bit more detail about the colon-rectum subdivision. Colon cancer goes to the MDT, has staging investigations including a CT scan, and then treatment is decided. Rectal cancer needs additional staging investigations. We need an MRI scan, and why is the difference? Well, the difference really is in one of the treatment regimes, because certainly for rectal cancer, radiotherapy is of course considered. And so suitable cancers are considered to have for short course or long course radiotherapy before surgery, which we know has benefits in terms of downstaging the size of the tumours and preventing or reducing local recurrence.
So the first group of patients that I'm referred to are the post-operative patients who have had what we have hoped to be a curative resection of their cancers. The problem is that unfortunately that isn't the case. And in roughly about 25% of patients who have a lymph node negative cancer and up to 75% of lymph node positive resected bowel cancers will recur in the first 5 years, the commonest time being 18 months to 2 years. Now those are quite impressively high figures of recurrence rates, and that's because people have unfortunately got micrometastases that haven't been resected at the time of surgery. And the short question then is there anything we can do to eliminate micrometastases? The short answer is, in some people, yes, and that's the role of chemotherapy. The nice guidance at the moment is to offer all medically fit patients with Duke C cancer, so lymph node positive, and for those deemed to have higher risk Dukes B, lymph node negative, chemotherapy. And the standard at the moment is 2 drugs, oxaliplatin and 5-FU, for 6 months. The challenge that we have, though, with offering patients with colorectal cancer chemotherapy in this setting is that obviously a proportion of the patients will have been cured already, and the chemotherapy doesn't work in everybody. So, for example, roughly the number of people who benefit from chemotherapy ranges from 2 to about 15%. So in fairness, chemotherapy fails in the setting the majority of people I treat. The problem is I just can't identify those people who will benefit. So you end up treating the whole group. I'll come on to the side effect management at the moment. So I offer chemotherapy to these 2 groups of patients. And I should say as part of that, actually, forgive me, is that age doesn't come into this. There's, as you all know, a whole new project ongoing in North East Thames at the moment looking at the management of patients with colorectal cancer over the age of 70. But there is a lot of data coming out now that if you have, for example, have somebody who's 85, who has a high risk bowel cancer and has obviously survived a right hemicolectomy, there is absolutely no reason why that patient shouldn't be offered chemotherapy, as long as A, they want it, and 2, they know the side effects. If you get to the age of 85, your median survival beyond that is another 7 years, so you've got time to get your recurrence. So we would offer chemotherapy to 85-year-olds. You do have to be cautious, however, because there is increased toxicity as you get older, so you've got to make a balanced judgment based on morbidities. This is where we've come in for over the last kind of 5 to 20 years, which is, before there was an age of chemotherapy, roughly 50% of patients post-operatively survived 3 years. Now the figures are up to about 72%. So there has been a big advance in giving chemotherapy, and it's why we advocate it post-operatively. In terms of the patients who've had curative resections, there is a huge trend now to follow the American example. In the States, the Lance Armstrong organisation have a big program for all patients, no matter what the tumour type, to have follow-up primarily by physiotherapists, OTs, dietitians, etc. How to live beyond cancer, how to get back to work, and in particular, two very important things, which is the role of exercise and diet in reducing the risk of cancer recurrence. And this isn't generic. This is specifically for colorectal cancer. There is very good evidence from the States that if you exercise at least 30 to 40 minutes, enough to make you sweaty, at least 5 times a week, you reduce the risk of that colorectal cancer recurring. And similarly for diet, the main advice is a low-fat diet and having a BMI within the normal range. So whilst during chemotherapy you may not feel like being very active, the minute we've finished with you, you need to be. And this is something that actually has been taken up very well by patients, because it's the first time we in the UK have been able to say, you need to now take this on board. This is something you can do for yourself now chemotherapy is finished. CEAs are only useful once you've had a bowel cancer diagnosed. It is not useful as a to kind of work out whether somebody has bowel cancer. What I normally say is, when I'm teaching students, is if you did a whole room, 20% of you would have an abnormal test, and it doesn't mean you have cancer. The other problem with CEAs is that they can be normal in people with advanced disease. So it's very specific for an individual. But if you have had a bowel cancer diagnosed, you should be having your CEA measured, but just don't rely on it to necessarily show you anything. Sadly, the other half of my job is to give patients advice on chemotherapy and treatments for the metastatic setting. And my aim here is to improve or maintain good quality of life. I generally don't say that it's to make people live longer, although in some diseases it can do that. And that's because, unfortunately, there are, as we all know, side effects which can be considerable with chemotherapy that might in fact shorten their lives. So I'm doing it primarily to make somebody feel better. Now, we all know that that's wishful thinking very slightly, because there is that terrible dilemma in the balance between the effects that chemotherapy has on an individual. Those are the 3 drugs that we commonly use in bowel cancer. We use them in varying combinations, either as single agents or in doublets. We don't tend to do triplets in colorectal cancer. And those are just kind of a span of the side effects that we'd commonly see. So mucositis, sepsis, nausea, vomiting, diarrhea, sterility, neuropathy being the commonest. About 92% will get some degree of neuropathy, of which 15% will have it residual at 4 years. So it's a significant burden for patients. But I just wanted to very briefly tell you about what we're doing beyond chemotherapy. Because what we know from the experience in leukemia, it isn't just a case of giving more drugs. And what we're looking at now is harnessing the differences between normal cells and cancer cells and see if we can utilise that as a treatment option. And the biggest difference is the ability of cancer cells to produce their own blood supply. So a cancer can only grow beyond the size of a pinhead if it develops its own blood supply. It does through 2 major pathways, and the overexpression of these are the epidermal growth factor receptor pathway. We know these are overexpressed in about 80% of colorectal cancers, and over the last 30 to 40 years there's now been developed monoclonal antibodies to block it. This drug is called cetuximab, major side effects being diarrhea and rash. That doesn't sound too bad, but the rash can be severe, acne formed over the face and neck. This is now licensed by NICE, so we give it with chemotherapy, particularly if we're trying to downsize a cancer prior to what's hoped to be curative resection. The second drug, second pathway, is vascular endothelial growth factor, again a receptor that's overexpressed in particularly high-risk bowel cancers. The monoclonal antibody for this is called Avastin, and the side effects are slightly different profile: hypertension, proteinuria, and perforation. So we do have to be careful with patients with metastatic colorectal cancer with this drug, because obviously if they have a big obstructing cancer, you're worried about the drug inducing perforation. This is not NICE approved, but about a year ago the government gave the country, if that's the right phrase, about £8 million to pay for these drugs that were not normally were too expensive for PCTs to afford. The cost of Avastin for a 6-month course to be given with chemotherapy is roughly about £50,000. So we now have these drugs available to us in various circumstances, and we're utilising them to the full. So we are now almost on a par with our colleagues in the States and in Europe who have had both of these drugs for some time. And this is where we've come to over the years since I've been doing oncology. The average survival, if you respond to all the drugs we have and we can throw at you, can go over to over 24 months. Unfortunately, if you are very unwell and you are not able to have any chemotherapy, the average survival is about 6 months. So how do we follow up colorectal cancer in the advanced setting? In fairness, we don't discharge them, not unless patients just don't want to come and see us. So if we're not offering chemotherapy, or if the patient themselves does not want any chemotherapy options, then we discharge them usually to the community palliative care team and yourselves. Otherwise, we keep seeing them, because in fairness, once they've had one bout of chemotherapy, you hope they have a period of time of good quality of life, but you know they're going to get further progression of that disease at some stage. So discharging them seems slightly disingenuous if they're going to come back to us. We do link them in with CNSs and key workers as their kind of liaison points, so that if they are well and they don't want to come up to clinic, then they don't have to, as long as somebody's just keeping an eye on them.
That concludes this webcast on colorectal cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites.